Dusty Lynn from the Life Support Learning Center, and welcome to Pediatric Emergency Assessment. This is part one of a multiple series where we're going to be talking about the Pediatric Assessment Triangle, the PAT. This is also called the Approaching Assessment. You may feel like this sometimes when you walk into a room and you know that you have a critically ill pediatric patient. Hopefully by the end of this series you're going to feel a little more comfortable about knowing what to do when you have those encounters. So our objectives today are to develop a rapid, systematic approach and have a hands-on assessment to all critical ill children, and to rapidly determine by that pediatric assessment triangle or that approaching assessment what our primary hands-on assessment is going to be. So our overview, we're going to discuss the pediatric emergency assessment. We'll talk about what it is, why it's important, and how to do it. There are essentially three phases of the pediatric emergency assessment. And again, this isn't the end-all ICU admit assessment. This is what to do when you walk into a room or mom comes up to you or you arrive on scene and you see a child who's clearly critically ill. What to do, how to start, what your primary assessment is, and what your priorities are. We have the approaching assessment, also known as the Pediatric Assessment Triangle. That's what happens as soon as you see this child. Again, it is not something that you're standing there and assessing. It is what you're automatically assessing as you're approaching the child or the child is approaching you in, say, mom's arms, a triage. And then what your primary assessment is, also known as the hands-on assessment. And then, of course, the final phase is that ongoing reassessment of what you've done or what you've assessed in the ABCs, as well as your secondary assessment. Why is this so important? Why is it so important to have that ingrained systematic approach in our mind? It's really what helps us to stay focused during a crisis situation. And oftentimes pediatric resuscitations can be very chaotic. If you've ever taken care of a child who was in, say, full arrest, and you have a parent in the background screaming, please don't let her die, please don't let her die. That's why you have to have that ingrained into your brain, what you need to do so you can stay on game and on point. The other reason why it's so important to have that systematic approach is because if you assess a child in the correct order, then you're going to treat them in the correct order as far as life-saving to maybe not so life-saving or life-threatening issues. So staying on your game in that systematic approach, very important. As you know, kids aren't just small adults. Their response to trauma and to illnesses can be very different than the adult. They can have compensated measures in place and then suddenly lose that ability to compensate. It is very important to understand and recognize that. If you don't assess it, you can't treat it. So having that systematic approach where you can stay on your game and again assessing in the right order so you can treat in the right order, very important. Kids can deteriorate very, very quickly. They can compensate to a point and then no longer. And when they get to that point where they can no longer compensate, they can become unstable very, very quickly. They can also have very serious illness and their presentation initially could be very subtle. So why do we miss important assessment pieces in our pediatric patients? Sick kids can be very, very stressful to take care of. You have your family members that are stressed. You have equipment that you might not use very often. You have skills that you may not use very often unless you're in a pediatric center where all you see are pediatric patients and a high number of sick patients. It's really easy to be off your game. So probably the number one reason why it's so easy to miss critical information is because we don't have a systematic approach. There's many different reasons why kids can end up in cardiopulmonary arrest, but oftentimes they filter down into one of two mechanisms. It's either a respiratory situation that's gone too long or a perfusion shock issue that's gone too long. By the time that they compensate and that compensation is no longer working, when compensation is falling, that's called cardiopulmonary failure. At that point, they're bradycardic and they're gasping, and they are just literally a breath away from cardiopulmonary arrest. So recognizing these kids when they're in respiratory distress, certainly when they're in respiratory failure, or when they're in shock, very, very important, because if we don't recognize it, they can rapidly go into cardiopulmonary failure, and that's really close to cardiac arrest. So what is this approaching assessment, the Pediatric Assessment Triangle? It's really what you're assessing as you're approaching this child. It's what you see and what you hear that is going to help you know what your primary hands-on assessment is going to be. It can be very, very confusing when you walk into a room and say this child was supposed to be something that wasn't very sick at all, and then you walk in and you see a child who's clearly ill. Seconds matter when encountering that patient, and you have to know what your next steps are. The nice thing is, in critically ill children, that you walk into a room and you really only have two pathways to take. One is you need to check a pulse right away, or two, you need to go ABC and check their airway. So those are our two options. The bottom line is, if the patient is breathing, that's always an ABC. If the patient is not breathing, that's a check a pulse, and then depending on whether they're bradycardic or pulseless, you either start CPR or you start bag valve mask ventilation. So why don't we just cut to the chase and say, look at their chest. If it's moving, you know they're breathing, and it's ABC. And if it's not moving, then that's a CAB, check a pulse. The reason why we keep that triangle, those three components of that approaching assessment or pediatric assessment triangle, is because we have to recognize that in the patient who is unresponsive, their chest can be moving, and that's actually gasping, and that's not effective ventilation and oxygenation. I can't tell you what it is, I can just tell you what it's not. And it is not effective oxygenation ventilation. I was taking care of a pediatric patient, infant, who had just had cardiac surgery and was on his overbed warmer, intubated. We were monitoring his ECG, his SATs, his radial arc line, LA line, RA line, capnography. And I looked over and I saw his chest just moving like he was gasping. I grabbed my stethoscope and went to listen to bilateral breath sounds, thinking somehow or another his tube came out, even though he was sedated. And by the time I got up and went right to him, 2 feet away, everything went flatline and he arrested. It's just something the chest does right as they're dying, and it's not oxygenation and ventilation. So you have to recognize that in the unresponsive pediatric patient who is gasping, it's the same thing as if they're apneic, and that's right to check a pulse. So again, CAB, if they're gasping, it's the same thing as apneic, and you need to check a pulse. Trauma is a little different. We're going to talk about it linearly, but the reality is in a team approach you have two things happening simultaneous. But if you are the only one who walks into the room and you see a trauma patient and they are spurting blood somewhere, clearly with the proper PPE you need to control the hemorrhage. Put a hand on it. Cover the dike. And then it's your ABC trauma assessment. If it's obvious exsanguination, you need to stop that, of course. So always be prepared. Are you ready? Do you know where your life-saving equipment is? Whether it's on the truck or whether it's in a room, where is the equipment you're going to need the quickest to save a life? So let's talk about the approaching assessment, the Pediatric Assessment Triangle. It involves the appearance or the affect, which is essentially what their level of consciousness is, their breathing, and their circulation is evidenced by color. Of course, their general appearance or affect, when you see a child like this, you're like, okay, got this. Clearly, she is not critically ill right now if she has that kind of cardiac output, that she can have that kind of response. This child, when you walk into a room and you see, again, what's her general appearance? Her eyes are open. She looks like she's looking at someone. And this is a child who is trisomy 21 Downs. And it's just a reminder that when you see a situation of a child with special needs, sometimes you have to ask the caretaker, the parent, What concerns you the most today? If you have no idea, you can't tell by this child what her real issue is, just ask the parents, is this how she would normally behave to strangers? Because Downs kids can fool you. At this age, she should be pretty fearful of a stranger, but she may well allow you to come up and do whatever you want unless you hurt her. And if you're not aware of that, you would think that that might be abnormal. So in a Downs patient, that could be very normal. So again, ask parents, ask mom or caretaker what's normal for her. In this child, she looks like she's looking at you and has no fight left in her. Lethargic, apathetic. This is very, very concerning. There's other things that you'll notice as you're approaching the child for general appearance, things that keep in mind for situational awareness. In the right upper hand, you see the two children that both clearly are HEMOC children that are probably immunosuppressed. So you need to know that because, again, you're going to be very protective over them infectious disease-wise and PPE and not exposing them to other kids. On the left of your screen, you see two little children that are preemies or ex-preemies. That's very important to know as well because then you automatically know, okay, these guys could have tracheobronchial malacia. And I need to ask mom if this is the case because in these kids, something as simple as starting an IV line could send them into respiratory distress because they have very soft airways. And if they start crying and screaming, they can collapse those airways, not get enough air. And the kids on the bottom right, you see they have muscular skeletal issues. And so again, you need to, as you're approaching these children, automatically you see something's different and you need to ask the caretakers what you need to know about how best to take care of them. So potentially life-threatening issues as you are approaching these children, their general appearance or their affect, certainly a lethargic child. If they have decreased mental status, certainly if you see them laying there and they're seizing, sometimes it's not so obvious. Sometimes you just see rhythmic activity of a digit and unresponsiveness, and that can be a seizure. Altered mental status could be an ingestion, lots of different things. But what do you notice as you're approaching this child about their general appearance or their affect? The other thing that you might notice as you are approaching them are different sounds. What kind of things might you hear? Clearly, you're hearing this child gasping for breath, and you might notice that as you're approaching them as well. So breathing, it's what you hear as you're approaching them and what you see. What is their work of breathing? Are they breathing or not? If they are exposed, and you can actually see, like in this child, you can see he's got retractions, intercostal retractions. So are they breathing fast? Are they breathing slow? Do you hear wheezing? Do you see a prolonged expiratory phase? Do you hear stridor? Do you see nasal flaring? Can you see retractions? And again, this is as you're approaching them, and it's your B breathing. So clearly if they're not breathing, if they're gasping, if they're breathing very slow, if they have a severe increased work of breathing, or if as you're approaching them or mom's bringing them to you, you see that they're breathing fast and they start to suddenly slow down, all of these are very life-threatening situations. So what about color? As you're approaching this patient, what is their color? What is their circulation as evidenced by their color? Pink is usually the goal, right? If they're pale, oftentimes they could be lacking volume or perfusion. Mottled, they could be red or ruddy. These are kids that can fool us. As we're approaching them, you think, oh, they look pretty good, they're pink. And then as you get closer, you realize they're peripherally vasodilated, and that's that red ruddy. And that could mean, again, anything from any kind of distributive shock that would cause this peripheral vasodilation. They could be gray. It's always bad. They could be blue. So you're approaching this child, and let's do our Pediatric Assessment Triangle, our approaching assessment. What do you think of his level of consciousness? He's looking right at you. He's got his eye on you. He's got that passy in his mouth, and he looks like he's going to punch you if you try to take it. That's a check. On the still slide, we don't see any breathing abnormalities. That's a check. But what about that color? What about his circulation? Well, clearly he's got enough perfusion to his brain because look at his mentation. So that really is a check. So what we're trying to see really is his mucous membranes and his nail beds, both of which are kind of hard to see, but they look pretty pink from here. And of course, what you see is this rash that's very, very obvious, but that's not necessarily what his central circulation is. So this rash, if you were to put your hands on it and touch it, you could feel it. There's pustules, it's puffy in some areas, crusty in other areas, and this is actually a chickenpox gone wild. And he looks great other than what's going on with his skin. So of course situational awareness with him is you don't want to put him in a room with infants or anyone who could catch varicella. So, but for purposes of advanced life support or critical care, he looks great. It's just this rash. Now, if you were to take this same child, lay him down and make him look, say, toxic, where he looks very, very sick, has a high fever, and you were to feel this rash and you can't feel it. It's under the skin and it's darker, it's purple. It's a petechial rash or purpura or ecchymosis. That, however, is a life-threatening rash, not only to him, but to you. So that's a situation where you want to stop what you're doing, you want to put on PPE, a mask, and get other people in there to help. Because that kid looks sick, and then you see by his color that there's a life-threatening rash going on. So, but this child on the slide looks great. Here's some other situations that you might see for circulation, some modeling. Sometimes it could just mean they're cold. Sometimes it means they're poorly perfused. Here is that petechiae that we were talking about, some ecchymosis and some purpura as well. Again, oftentimes very indicative of critical illness in the pediatric patient. Here's some evidence of cyanosis. And you'll notice on the top left of this baby, if you look at what I call a mustache in the beard area, it's discolored, and oftentimes you'll see that color start to change before he has real circumoral cyanosis or central cyanosis. So that is something to also look for. So certainly if they have extreme pallor, if they have this petechial rash, if they are cyanotic, those are potentially life-threatening situations, and you need to get the appropriate help. So that is your Pediatric Assessment Triangle for your patients. And anytime they're breathing, you know your hands-on primary assessment is going to be A, B, C. And we'll talk about that in another presentation. So again, I'm Dusty Lynn from the Life Support Learning Center. I'm the pediatric educator there. And thank you for spending some time with us to cover the Pediatric Assessment Triangle, or the approaching assessment. Hi, welcome to Life Support Learning Center Pediatric Education. My name is Dusty Lynn, and I'm the pediatric educator at the Life Support Learning Center. Today, we're going to discuss the beginning part of pediatric emergency assessment, the Pediatric Assessment Triangle. The pediatric emergency assessment is actually 3 components, and it contains the Pediatric Assessment Triangle, the ABC assessment, and the situations where you'll start off with the CAB assessment. We hope you'll join us for the classroom presentation of the same thing in greater detail, where we actually go over the cases. So, the ABCs of the Pediatric Assessment Triangle: A stands for general appearance. B, are they breathing? And C, what is their circulation as evidenced by their color? Let's discuss each one. So general appearance, or affect. As you're approaching them, how are they reacting to their environment? Are they laying there flaccid, unresponsive? Are they fussy? Do they look like they're having seizures? All of these things compose how they're interacting with their environment. What is their affect? What is their general appearance? B stands for breathing. Again, this is as you're approaching them. You're not standing by them assessing this. This is as the patient is coming towards you or you are going toward the patient. Are they breathing? Can you see? Sometimes you may not be able to see. If mom walks up to the triage desk and she's holding a baby in a blanket, as she's coming towards you, you may not be able to see whether or not he's even breathing. And then see circulation. What is his color? Can you see his color? And of course we're looking for the central or the core color. We're looking for the mucous membranes, his nail beds if you can see those. But A, B, C, general appearance, are they breathing, and what is their color or their circulation as evidenced by their color. Another component of the A, sometimes you might hear as you're approaching them airway sounds, and we'll talk about that in greater detail when we go over ABC, but sometimes you may hear airway sounds, which would also be part of the A as you're approaching them of the Pediatric Assessment Triangle. And what you do with that is very important. For all patients, if they are breathing, you can see that they're breathing, then your hands-on assessment will always be A, B, C for airway, breathing, circulation. If they're not breathing, then that's always, I got to check a pulse right away. Are they pulseless or are they severely bradycardic? So again, that approaching assessment, that pediatric assessment triangle, very important because that is your indicator of what your hands-on or your primary assessment is going to be. So let's review that. As you are approaching the patient or the patient is coming towards you, the pediatric assessment triangle, A, general appearance, their affect, how they're reacting to their environment. B, are they breathing or not? And C, what is their color? And with that, you will know what your next steps are. And that is the pediatric assessment triangle.